invite Dr. Simran to present regarding overcoming postoperative hurdles, managing challenges after phacoemulsification in uveitic cataract.
Good morning, one and all. I'm Dr. Simran, junior resident from MGM Navi Mumbai, and I'll be sharing with you how we overcame post-operative hurdles after phacoemulsification in a uveitic cataract. Uveitic eyes account for approximately 1.2% of all eyes undergoing cataract surgery, and managing cataract in such patients is often challenging due to chronic inflammation. Furthermore, the corticosteroids commonly used to control uveitis can inadvertently accelerate cataract formation. Case report. A 50-year-old male presented with gradual painless vision loss in both eyes over 3 years associated with on and off redness. Patient was a diagnosed case of chronic uveitis under treatment and denied any history of trauma, infection, joint pain or any systemic illness. On examination, visual acuity in right eye was HMCF, PL positive and PR accurate, while in left eye was finger counting at 3 meters. On examination of both eyes, conjunctiva was congested, cornea had fine keratic precipitates, anterior chamber was shallow in the periphery, there was annular posterior synecdoche, dense cataract, and IOP was 10 millimeters of mercury. Fundus details could not be seen, and USG-B scan was within normal limits. The patient was planned for right eye phacoemulsification. The synechial adhesions were released through the side port. Pupillary dilatation was achieved through iris hooks. The cataract was then emulsified and there was implantation of hydrophobic intraocular lens. The surgery was uneventful and patient was started on topical steroids and antibiotics. This is how the patient's eye looked at POD1 with minimal edema in the cornea, well formed and quite AC. At POD10, the visual acuity was 6/18. At POD 30, patient complained of sudden diminution of vision. On examination, visual acuity was 6/36, cornea was clear and anterior chamber was quiet. Dilated fundus examination was suggestive of macular edema, which was then confirmed by OCT. CMT was 568 microns, for which intravitreal triamcinolone alone was administered. At POD 38, there was further decline in vision to 6/60. Anterior chamber was shallow in the periphery. There was annular synecdoche and IOP was 24 millimeters of mercury. The patient was started on anti-glaucoma medications alongside topical steroids and antibiotics. At POD 49, the visual acuity further declined to figure counting at 2 meters. There was microcystic edema in the cornea. Anterior chamber was shallow and there was iris bomb formation with IOP of 40 millimeters of mercury. Along with anti-glaucoma medications, patient IOP was managed conservatively using intravenous mannitol and glycerol. Despite the conservative management, IOP consistently remained above 28 millimeters of mercury. Therefore, NDAG laser peripheral iridotomy was done at POD 52. At POD 68, the visual acuity had improved to 6/12, cornea was clear, anterior chamber was normal depth, IOP had reduced to 10 millimeters of mercury, and cystoid macular edema had also reduced with a central macular thickness of 120. On subsequent follow-ups, IOP was maintained within 10 millimeters of mercury with visual acuity continuing to be 6/12. Patient was planned for left eye phacoemulsification with hydrophobic IOL implantation. And in this case, in the other eye, intraoperative prophylactic peripheral iridotomy was done to prevent post-operative rise in IOP. At 4-month follow-up, the visual acuity in right eye was 6/12, while in left eye was 6/9. Anterior segment was within normal limits. IOP was maintained in the within normal limits, and it was below 10 millimeters of mercury. And fundus examination was within normal limits. So uveitic cataracts are typically complicated by presence of posterior synecdoche and poor pupillary dilatation, necessitating intraoperative pupil manipulation to achieve dilatation. These manipulations exacerbate post-operative inflammation, increasing the risk of CME, elevated IOP, and PCO formation. In our case, while we planned the other surgery for the other eye, we planned an intraoperative prophylactic peripheral iridectomy to overcome the hurdles that we had experienced in the previous eye. So in conclusion, Perioperative operative control of inflammation is necessary using topical steroids in cases of uveitic cataract, that we all know. But also we can, in this case, we achieved benefits by doing the peripheral iridectomy in the other eye. Under the iridectomy was pretty large in size, and it was done under the steroid cover, which reduced the post-operative chronic inflammation. Other than that, hydrophobic implantation, hydrophobic lens implantation was also considered to reduce the inflammation. So addressing the dual aspects of inflammation and cataract formation is the key to successful treatment in uveitic cataract. These are my references. Thank you.
Why you thought that iridectomy should not be done in first case? In all these cases, when you have mostly you get the peripheral synechiae or the posterior synechiae?
Posterior synechiae, sir. In this case, the posterior synechiae was present, but there was already a lot of inflammation. So in the first eye, we did not.
There must have been iris Bombay and then you got the posterior synechiae and all that. What I'm saying is iridectomy is better must in all these patients.
Yes, sir.
Mixed steroids preoperative.
Yes, ma'am. After at presentation, the patient was immediately planned for surgery because of an emergency. But for the other eye, the patient was started on on oral steroids prior to the surgery, and even topical steroids were given.